Welcome to this special edition of Around the Rheum. Sad to say, this is the last of our daily roundups of the most interesting and essential topics from the CRA's 2025 annual scientific meeting here in downtown Calgary. As always, I'm very happy to be joined in person by my excellent co-host, Dr. Janet Pope. How are you, Janet?
I'm doing great.
You're surviving 3 full days of ASMing?
It was a busy ASM, but the party's coming.
Okay, great. And you always bring the energy there. So back with us again today are two of Canada's absolute best rheumatologists to help break down day 3 of the ASM for you. The University of Alberta's Dr. Mo Osman. Mo is also the abstract chair and co-chair of the ASM Planning Committee, and the University of Calgary's Dr. Marinka Twilt, who is the ASM Program Committee chair. Welcome back to you both.
Thank you. I'm just sad we're not doing a recap of the party tomorrow.
That's true.
Totally agree.
Yeah. So lots happening on day 3 of the ASM in Calgary, so let's get into it. Maybe today we'll start with you, Dr. Twilt. What were 3 topics that caught your attention today that you wanted to share with everyone?
Well, of course, I cannot not mention a Dunlop doctorate lecture by Daphne Glatman. Daphne gave a great overview, and I think as a pediatric rheumatologist at the end, I had a lot of envy for all the medications that are available now for psoriatic arthritis because they are not available for our pediatric patients. Mm-hmm. So it was great to see the success that there is in the adult world, but I would love to see that we can show that the success is the same in the pediatric world. But hopefully we'll get there with the next Dunlop doctorate lecture on psoriatic arthritis in a couple of years. Totally. But that was for sure a highlight, that session.
I always like a lot of doctors will do this on their presentations, some a little bit of history of the disease. I always find that fascinating. So I really like the rest of the lecture was also brilliant.
The Mall and Wright criteria.
Yeah, exactly. I thought that was a really thoughtful lecture. Okay, what else?
Yeah, and then I went to a workshop. So I went to the workshop 3F, starting and stopping medications for children and young adults with arthritis, what matters for effective shared decision making, which was led by Dr. Daniel Horton, Dr. Jaime Guzman, and Natasha Trehan. And Natasha is a patient with arthritis who actually started Pain Check, which is a foundation. And it was really great to hear her perspective as well on stopping and starting medication, and hearing that she took a pause at one point because she and her family were just not ready at that moment to talk about biologics, and it actually has led to damage. And I think it's really worthwhile hearing that, because I think she also made clear to us if she had gotten maybe a little bit more information at that moment about why she was hesitating, which was the fear of unknown medications, the potential side effects, then maybe they wouldn't have paused that long, and maybe she wouldn't have had damage. And Dr. Guzman and Dr. Horton really talked about shared decision making and how to do that and how to incorporate that in clinic. I think the biggest struggle is still that we don't really know how to stop in pediatric patients, and a lot of patients also go to the adult world, so we don't even know what happens with them when they are finally stopping their medication. But this at least is sort of a way to examining it with the patients as well in a shared decision model, and I think that's a really hopefully a bright light in the future, and how we can stop and also start medication. It's not just stopping, but also how to start some of the newer medication if we don't have that much data yet.
Definitely. That's a tricky topic. I do actually find, beyond the starting medications, the stopping medications I find to be challenging in ANCA-vasculitis, at least, right? Many people stop after 2 or 4 years, but we know it's a really bad disease. So saying we're going to stop and we'll see if you relapse, that's a really uncomfortable conversation. Some patients are very ready for that, and they're can't wait to be off this stuff. And some people look at you sideways being why would you take this away? Why would you fix what's not broken? So I find that a challenging conversation.
Yeah, and
sometimes.
I think with the adolescents, what the struggle is, are they going to be, and honest is not the right word, but are they going to, notice when they have symptoms, and do they want to mention it because they know it means going back on medications, and that has implications for a lot of their social activities potentially. So I think that is always the worry in the young adults, and I'm sure that's also with young adult population in the adult world, not just in the pediatric world, that you're struggling, are they going to be honest, or are they just going to like come when it's like they have damage, and in
Right.
JIH, damage of their joints, but in lupus, we know they come with kidney failure afterwards, and then
Yeah.
they potentially need a kidney transplant. So yeah, it for sure is very impactful if you stop it and they do flare.
I think the bottom line, too, is we don't really know who's taking what when. I think in general, if they know the name of the drugs and how they're taken, in general, they're probably taking it, but are they taking it as prescribed? Not necessarily.
Yeah, no, I totally agree, Jeanette.
All right. And what was the last one that you wanted to
Well,
highlight?
I cannot, like the last one needs to be Joan Wither with her Distinguished Investigator keynote address. I mean, it was a pack full lecture, but it just shows sort of like the major successes I think she has made in her translational research with all her collaborators. And I think it shows that in pediatric rheumatology, we still have a lot to follow as well in that world. But also, again, promising potential new biomarkers that can help with disease progression, or potentially even if you will develop the disease, right? Which is also for us, we get a lot of patients with ANA positivity. Do we need to follow you? Are we medicalizing you? Well, you actually don't have to be medicalized. And I think this is really important work as well. So I was very impressed with her presentation.
I think some of the like predicting onset or like early disease and catching it even before it's fully symptomatic, I think that dovetails somewhat with the the debate about ultrasound, right? Because part of the point there was that you are going to have people with subclinical synovitis. That is what ultrasound can show you, right? And trying to decide who does need treatment, who doesn't, who is actually going to go on to real significant disease, and who is it's going to fade away. I think having biomarkers and other tools to kind of put all of this, like we're collecting data and we're not totally sure how it all fits together yet, but it seems to sort of dovetail with that kind of concept. Brilliant. Dr. Osmond, let's turn to you. Were there kind of 3 presentations that stood out to you?
There were a lot more than 3 presentations that stood out to me today, but the 2 that really stood out to me were the one by Dr. May Choi. Not surprisingly, she was given the Emerging Investigator Award. She's doing fantastic work. She presented some of the work that she's doing related to AI, where they're looking at the performance of an AI versus a very experienced technician looking at slides, and they're looking at comparing something called the DSF-70, which is helping really rule in versus rule out, I guess, a systemic autoimmune rheumatic disease. And the thing that came out of this discussion to me was, well, what happens when the AI is not really sure? And to me, that was, is this information that we can use and kind of identify new patterns that were missed potentially by the technician, or something that the technician can kind of go back to. So I felt that was kind of a really interesting podium presentation that I really enjoyed. The second presentation that I enjoyed also as a podium presentation was the one by Dr. Timothy Kwok from the University of Toronto. And this is not something that I'm very familiar with in Alberta, but he really touched on some of the discrepancies related to remuneration across Canada, and some of the kind of the subtle differences, and how this can impact time patients spend with a rheumatologist, and how we can really use that information to advocate for care and harmonize these changes related to remuneration. So I think that was really good.
That is if we can just comment on that does come up with some frequency, at least at our centers. I'm sure this happens at yours, where many people are fee-for-service and some people are salaried or on an alternative pay program. And it clearly changes the way you move through patients, right? If you are paid by how fast you are, not necessarily by how thorough you are, then it relies on the goodness of your heart to kind of go that extra step. And thankfully, our colleagues do have good hearts. But I think the incentives are, it can be difficult, it seems, to kind of manage the incentives.
And to add to that, so telemedicine in some places is reimbursed equal or almost as good as in person, and in other places it's almost delisted. It's very
Right.
low if you don't have the video camera on the right platform, etc. And I was struck by the fact that only 2 provinces, so BC, as you know well, and Quebec, have a nurse model or an allied health professional that can help do comprehensive care, and that there's sort of a reimbursement code to enable the reimbursement for that person who can help our patients a lot. So I thought that was also really interesting.
Yeah, I suppose, like, broadly speaking, the way you structure remuneration is going to incentivize behavior, and it's going to change care. Even if everyone's trying to do their level best to take care of people.
I completely agree. And I think the thing that really struck me was, even though, first of all, not all provinces offer remuneration for ultrasound when it comes to ultrasound assessments for rheumatologists, but I wasn't aware of the value. And the value is very nominal. It's like $24 or something like this for a consult, which I didn't realize, because especially when you're spending that kind of time with a patient, you're spending a lot more than that time. So you're doing it clearly because you're passionate about ultrasound and you're trying to provide good care. So I thought that was really interesting and eye-opening for me.
What else did you see today?
Well, the Dunlop Dottridge lecture, of course, is a highlight in every CRA, and this was no exception. So Dr. Gladman, I think, really provided a really nice overview for the journey, or her journey, through psoriatic arthritis over the years, and how things changed really over the course of her lifetime, which I think not many people can say they kind of witnessed. And I think it just speaks to how exciting of a time rheumatology is right now. There are many changes happening. Psoriatic arthritis is a great example for this, and obviously Dr. Gladman was really one of the leaders that really has inspired a lot of these changes.
You had a chance also to go through the poster presentations today. Were there ones that you wanted to chat about?
Yes. So as always, I am very biased, and I will talk to you about my biases. So I went to the poster tour. So poster tour 7B, which was the basic science poster tour. And this was moderated by our excellent Dr. Hani El-Gabalawi. There were 4 posters that were mentioned, but the 2 that really stood out in my mind that are potentially very relevant to rheumatoid arthritis, something that all rheumatologists I would say should be aware of, are the ones by Dr. Liam O'Neill from the University of Manitoba, and also Dr. Lillian Barra from the University of Western Ontario. Specifically, they're entitled Investigating Homocitrulline-Specific T-cell Responses in Rheumatoid Arthritis by Sofia Olanova, which is one of Dr. Barra's students. And in that poster, first of all, I have to commend them for the work. They are working on identifying specific T-cell populations that identify this different type of citrullination called homocitrullination, which is not the other type of citrullination which we are more familiar with. And they're really working from patients, and then now they're kind of building this, I think, into their animal model. She didn't present her animal model data, but I read the abstract, and I think they're definitely working on it. So I think it's very interesting, and I think I can see this totally moving from the true preclinical mode to the kind of clinical world very, very soon. So this, I thought, was really exciting.
And this is as a biomarker of disease.
This is a biomarker and potentially kind of a way for identifying these patients earlier, so that we can potentially use or even target these antigen-specific T cells, I think, down the road. So I think it's really exciting, and I can totally see this kind of evolving in the next, hopefully not too long, but I can totally see this kind of going in a very positive direction. The other one was by Jeba Meisha. So Jeba Meisha is one of Liam O'Neill's students. She presented something called impaired neutrophil extracellular trap net degradation in rheumatoid arthritis and preclinical arrays mediated by anti-net antibodies. So what does this mean? So in essence, netosis is something that we know happens in rheumatoid arthritis, and we know that netosis is probably very important in the generation of these anti-citrullinated antibodies. So what Jeba did, which was really cool, is that she basically used samples from patients with rheumatoid arthritis compared to FDRs, which are first-degree family members of patients who have this common HLA haplotype, and she identified a few of these citrullinated peptides. But what's really interesting is that she also identified an autoantibody, or an antibody, I should say, that really hides the location for where these citrullinated antigens are on these nets. And when these antibodies are present, this promotes basically the formation of these citrullinated antibodies, I guess. So this was inspiring because I think similar data was published in, I think, lupus a few years ago, and I think this was something that I think was interesting to me.
That's fascinating. Janet?
Net cells are a big deal.
Yeah,
I don't understand
absolutely.
it, but they seem to be a big deal in a lot of our chronic autoimmune diseases.
Absolutely. All right, Janet, you've had a busy day.
I have had a busy day, so just a couple things to report on. First of all, students at all levels, undergrad, medical students, residents, masters and PhD candidates, the PGY 4, 5, and beyond. I talked to all sorts of people today, so that was really cool, and just shout out to all of them. We welcome you in the CRA, and we do want you to become rheumatologists. We'd love it. So a couple things. So Lori Pruill, who is a patient with rheumatoid arthritis, and she clearly has said that. She does social media for the early arthritis Canadian cohort, the CATCH cohort, and she had various presentations and oral today, some learnings as well. And I think it's important that we translate the knowledge to the end users who are the patients. So there were sort of 15 learnings from the early arthritis cohort, and just a couple of them. If we get people in earlier and we do effective treatment up front, we're more apt to get them off drugs down the road. We don't aim for getting them off drugs. We aim to keep them in remission. Glucocorticoids in the long term are really not a positive thing, and they're probably a surrogate to people doing worse, because in the end, if you're glucocorticoids, you end up at the same sort of disease activity score, but you start higher and you have to move on more to advanced therapy. So that's just a couple learnings of very many. I went to the poster tour number 8, so Marie Clements Baker was basically guiding it. And of the 4 posters, 3 were from Ottawa. They were all great, but I'm going to talk about 2 Ottawa ones. So Dr. Swami is someone who has learned ultrasound and has learned ultrasound on an extra level of training for joints with Dr. Aiden, but also has learned how to do GCA, so temporal artery ultrasounds. And she had a nice poster of their experience. She said you need to do around at least 50 a year to 300 to sort of have competency, and she said their numbers are getting up to that. But she found that the gold standard would be what the doctor was going to treat. If they said it was GCA, then that had to be the gold standard of yes. And if it was an equivocal ultrasound or negative and they still suspected it, they'd go on to biopsy. So that was their algorithm. Their specificity, so positive predictive value is probably a better way to say it, was 100%. They had about an 87% sensitivity, so some did have to go on. So I thought that was really neat, and it did show like she had had all this extra training to get there. Mm-hmm. Then Sibel Aiden had a couple posters, but one of hers, even though you say I don't talk about ultrasound too much, it was a really cool question. It was a clinical question. So she said, when you're ultrasounding the hands of someone, they might or might not have disease activity, but you're wondering. So she said, what happens if they have tender joints and no Doppler signal? And what happens if they have a Doppler signal and no tender joints? So in both cases, there's a higher likelihood of those folks going on to flaring. But it's far higher, as you might suspect, if you have that positive Doppler signal, and far higher than a grayscale alone. And I thought that was really interesting because I sometimes downplay a tender joint, and because I'm not doing routine ultrasound, I don't even know if they have Doppler, high Doppler signal if they're not tender. But I thought that was a neat way to look at it. And so she said, finding these joints is not created equally, and we probably need an algorithm that might help if we're going to use ultrasound as a tool to change our practice. Definitely. So, and then the final thing was, I thought the awards were very heartfelt. Mei Choi as the emerging, she's already emerged, she's blossomed, she's a butterfly, came out of the cocoon. So the emerged investigator, formerly known as young investigator, looking at Dana Jerome, of an excellent clinician, teacher, educator, educator and for the Educator Teacher Award, looking at our Dunlop Dotteridge with really the powerhouse of Dr. Gladman, as we already discussed it, looking again at the other lectures, having Joan Wither and her award, so well deserved as a senior investigator, and Ray Young. And Ray Young is my idol. So Ray Young can make a complex problem so easy to understand. She's a networker. She does everything with a smile. She really does. And she really, I think, brings out the best in people. And that's why there's a lot of networks with a lot of good, as they need, excellent funding in pediatrics. So well deserved. So I think that would be, the highlight of my day, seeing the awardees.
Well, thanks to everyone for chatting today. We all got to go put on our dancing shoes because there's a gala tonight. Any dance moves that you're gonna break out today?
Just the usual.
Oh, the usual. Okay. Well, I'm really looking forward to that. So that's it for this last of our special 2025 ASM episodes of Around the Room from Calgary, Alberta. A special thank you to the podcast team, Dr. Dax Rumsey, Dr. Janet Pope, Dr. Mo Osman, Dr. Marinka Twilt, David McGuffin of Explore Productions, and Aaron Stewart. Our theme music was composed by Aaron Fontwell. For more information on the important work of the Canadian Rheumatology Association, visit rheum.ca and be sure to follow us on social media. I'm Daniel Ennis, and we'll chat again later. Take care.
That's a pod.